Good afternoon, everyone. It is a great pleasure and honor to have an opportunity to present my topic in this prestigious society meeting. Cholangiocarcinoma is well known for displaying a variety of imaging features. The varying appearances of cholangiocarcinoma may be attributed to various cells of origin of the tumors, such as major cholangiocyte, peribiliary gland, hepatic progenitor cells, and major hepatocyte. In addition, different anatomical environment or location of cholangiocarcinoma may also contribute its varying appearances on imaging. Moreover, the imaging features of cholangiocarcinoma also depends on its macroscopic growth patterns or growth types, namely mass-forming, periductal infiltrating, and intraductal growing. This morphological classification has been considered valuable for understanding the imaging features and differential diagnosis, for predicting tumor spread and prognosis, and for planning the management. Classical form of mass-forming cholangiocarcinoma can be characterized morphologically by a homogeneous mass with an irregularly lobulated margin and absence of capsule. On microscopy, you may see abundant viable cells in the periphery and variable degree of fibrosis and necrosis in the center. The typical feature on cross-sectional imaging include regular peripheral enhancement and gradual centripetal enhancement. In addition, capsular retraction, satellite nodules, and vascular encasements are common, with dilation of bile ducts and lymph node metastasis. The second type is periductal infiltrating type. This type is characterized by growing of the tumor along the bile duct without a discrete round mass formation. On CT and MRI, diffuse ductal wall thickening and increased periductal enhancement can be seen with upstream duct dilation. This type is relatively uncommon in the intrahepatic cholangiocarcinoma, while most perihilar tumors present with this growth pattern. Intraductal growing type mainly occurs in IPMB. Duct dilation correlates with the degree of mucin production and may show diffuse or localized cystic dilation, with variable size of macroscopic or microscopic papillary lesions. However, there may be some problems in classifying cholangiocarcinoma into these three growth types. In early papers where cholangiocarcinoma was classified into the three types, the mass-forming type occupied an absolute majority. However, in later papers, various mixed types have been reported, and such mixed types are the cause of discrepancy in imaging and pathological classification. For example, in this slide, you see three different growth types of cholangiocarcinoma that were classified as mass-forming, periductal infiltrating, and intraductal growing type respectively on imaging. However, in the pathological report, they were all differently reported as mass-forming plus periductal infiltrating plus mass-forming, and intraductal growing plus periductal infiltrating and mass-forming types respectively. Here we see uncontroversial and controversial cases of growth types. The lesion on your left and middle show uncontroversial cases of mass-forming and periductal infiltrating type respectively. However, the lesion on your right side may be controversially interpreted as mass-forming, periductal infiltrating, or mixed type according to the readers. So, when this tumor is included in the periductal infiltrating tumor, the whole periductal infiltrating type tumors may be characterized by advanced or poor prognostic type. However, when only the pure form, as in the middle, is considered as periductal infiltrating type, the periductal infiltrating type tumor may represent small and uncommon tumor with better prognosis. These two cases are similarly sized and shaped tumors. Both tumors are growing around the large bile duct. However, the left one is reported as mass-forming postperiductal infiltrating type, and the right one is reported as mass-forming type. The tumor shown here appears to be a periductal lesion on ultrasound or CT, but it is a region that can be classified as periductal infiltrating plus mass-forming in surgical specimen. In such tumors involving large ducts, the distinction between mass-forming and periductal infiltrating or mixed type is ambiguous. Therefore, in my opinion, a pure type of periductal infiltrating cholangiocarcinoma is likely to represent a transitional form of cholangiocarcinoma in the way of progression to mass-forming postperiductal infiltrating cholangiocarcinoma. It is because pure form of periductal infiltrating cholangiocarcinoma are relatively uncommon and smaller than mass-forming or mixed types, and also show better survival than mass-forming or mixed types with lower incidence of metastasis. The imaging findings of cholangiocarcinoma may also differ depending on the underlying disease. In the cases of cholangiocarcinoma associated with cholangiocarcinoma, mass-forming or mixed type seems most common. Duct dilation due to tumor or underlying cholangitis is commonly accompanied in both the peritumoral and remote liver. In this example, you may see larvae and eggs in the bile duct and periductal fibrosis and inflammation along the bile duct. On the other hand, cholangiocarcinoma associated with hepatolithiasis or intrahepatic stone disease is mostly associated with periductal infiltrating or mixed type. Cholangiocarcinoma can develop in about 10% of hepatolithiasis, and up to 70% of cholangiocarcinoma in the endemic area is accompanied by hepatolithiasis. It is said that cholangiocarcinoma occurs on average 8 years after diagnosis of hepatolithiasis. Interestingly, cholangiocarcinoma associated with chronic liver disease have different characteristics. They are often found in a relatively small size, probably because they are found during a surveillance program. And these tumors are often difficult to distinguish from HCC because they frequently show arterial phase hypoenhancement and washout, and are surrounded by fibrotic pseudocapsule. Now, let's see the difference according to the histologic type. Traditionally, cholangiocarcinoma has been classified into well, moderate, and poorly differentiated types. However, cholangiocarcinoma is recently classified into small bile duct type and large bile duct type according to various characteristics. The small bile duct type cholangiocarcinoma is typically composed of cuboidal cell or low columnar cells with scant cytoplasm and large nuclei, and show tubular or ductular pattern of growth. In contrast, large bile duct type is composed of tall columnar cells with eosinophilic cytoplasm and characterized by low cellularity and abundant mucin and fibrous stroma. The concept of small and large duct type in the classification is useful to understand the carcinogenesis and evolution of cholangiocarcinoma. The small duct type is associated with chronic liver disease and progressed to mass-forming cholangiocarcinoma or cholangioulnocellular variant without known precursor. In contrast, the large duct type is associated with chronic biliary inflammation, arises as bilin or IPMB as its precursor lesion, and progressed to periductal infiltrating, intraductal growing, or mixed type cholangiocarcinoma. There have been some attempts to predict histological type by imaging features. According to previous studies, small duct type more commonly shows non-rim arterial phase hypoenhancement, weak enhancement on the delayed or hepatobiliary phase, infrequent target appearance, and larger area of diffusion restriction. In contrast, large duct type tends to show rim or poor arterial phase hypoenhancement, stronger enhancement on delayed or hepatobiliary phase, frequent target appearance, and smaller area of diffusion restriction. However, these differential imaging features are mostly overlapped with each other. Here we see variable appearance of arterial phase or delayed enhancement, target appearance, or diffusion restriction within the same small duct type. Also, in the same large duct type, those imaging features are not typically represented to one histological type. In my opinion, the main difference between the two types is whether a tumor is associated or not with peritumoral duct dilation. So, to summarize the background, classification of cholangiocarcinoma into three growth types is sometimes controversial. Current histological classification into small or large duct type is useful to understand the pathogenesis and evolution of cholangiocarcinoma. However, the relationship of imaging features and this new classification is not yet well known. Therefore, we recently conducted a study to define the relationship of imaging features and the new histological classification and proposed an alternative imaging classification based on the recent histological concept. In our dichotomous imaging classification, we classified cholangiocarcinoma into parenchymal type and ductal type based on imaging appearances. The parenchymal type was defined by absence of duct dilation or other evidence of biliary disease. The ductal type was defined by presence of adjacent bile duct dilation, periductal tumor spread, or diffuse biliary abnormality such as dilation or IH dystons. This is an example of parenchymal type. Although the mass is larger and located in the center of the liver, there is no bile duct dilation and there is no evidence of biliary disease. This is another example that can be classified as a parenchymal type. There is evidence of cirrhosis, but no biliary disease and no duct dilation around the mass. Unlike the previous two cases, this is a case that can be classified as a ductal type. The mass is invading the bile duct and causes peripheral duct dilation. And the same findings are shown in the surgical specimen. This is another example of ductal type. Infiltrated mass with poorly delineated boundary is observed in diffusion-weighted images, T2 and hepatobiliary phase images, showing a pattern growing around the dilated bile duct. So, when we analyze the clinical pathological characteristics between these two types of tumors, we found that ductal type can be characterized by more frequent node metastasis, perineural invasion, association with Berlin, and elevation of CA and CA99 than parenchymal type cholangiocarcinoma, while parenchymal type cholangiocarcinoma is characterized by more frequent association with viral hepatitis. Another interesting finding was that although there is no difference in disease-free survival, the overall survival was significantly higher in parenchymal type than in ductal type. This may be due to the recurrence in the parenchymal type was limited and repeat treatment was possible and the response of the treatment was better. So, when we incorporate our new imaging classification with the current concept of cholangiocarcinoma, the small duct type cholangiocarcinoma may correspond to the parenchymal type cholangiocarcinoma on imaging pattern, and the large duct type cholangiocarcinoma to ductal type on imaging. In fact, this case shows a parenchymal type tumor on imaging that corresponds to a small duct type on histological examination. we see a hypervascular parenchymal type tumor without ductal dilation, periductal spread, or background biliary pathology on imaging. Histologically, the tumor shows small duct features on H&E stain with absence of expression of muscarmin or CRP. This is also an example showing a parenchymal type tumor corresponds to a histologically a small duct type. A hypervascular mass located in the center without bile duct dilation is consisted of cuboidal cells on H&E stain, positive for small duct type markers CD56 and NCAM, and negative for large duct type markers S100P and mucin. This is a case that shows the ductal imaging type corresponds to a large duct type. Peritumoral duct dilation is shown, indicating a ductal imaging type. The tumor is composed of columnar cells rich in eosinophilic cytoplasm in H&E stain, and shows positive for large duct type markers muscarmin, S100P, and TFF1. This is another case where the imaging ductal type matches histological large duct type. The left liver mass shows findings of large duct involvement. Microscopically, the tumor showed a large gland of tall columnar cells, negative for small duct type marker CD56, positive for large duct marker S100P, and containing a large amount of mucin. However, there is an important caveat for the matching of the imaging type and histological type, because some histological small duct type may mimic imaging ductal type. This tumor can be classified as imaging ductal type by showing the findings of ductal invasion. However, it was a small duct type histologically. This kind of mismatch can happen when a small duct type tumor happens to show ductal invasion. However, almost all imaging parenchymal type is likely histological small duct type. This is because most of histological large duct type tumor presents some degree of ductal abnormality even at early stage. So, imaging parenchymal type tumor defined by absence of biliary abnormality highly suggests histological small duct type tumor. In summary, in our dichotomous imaging classification, we classified cholangiocarcinoma into parenchymal and ductal types based on imaging appearances. The parenchymal type is characterized by absence of duct dilation or other evidence of biliary disease. These tumors correspond to the pure mass-forming type among the existing growth types, and pathologically it represents a small duct type, and the prognosis seems better than the ductal type. The ductal type is characterized by presence of adjacent bile duct dilation, periductal tumor spread, or diffuse biliary abnormality such as dilation or IHD stone. These tumors often represent periductal infiltrating, intraductal growing, and mixed type tumors, and histologically large duct type tumors. In conclusion, cholangiocarcinoma may show various imaging features depending on the origin, anatomical location, growth pattern, and histological characteristics. The imaging classification of cholangiocarcinoma into parenchymal type and ductal type is simple and easy to apply and may help understand the clinical and pathological characteristics of cholangiocarcinoma.